The neoadjuvant and or adjuvant immunotherapies have really changed clinical practice over the last few years. Specifically, we have two landmark studies that led to the approval of immunotherapy in this setting, specifically the CheckMate 816, which are randomized phase III clinical trials that assess the efficacy of neoadjuvant chemoimmunotherapy with platinum-based chemotherapy with Nivolumab, anti-PD-1 inhibitor, versus chemotherapy alone in patients with stage 1B to 3A non-small cell lung cancer, where stage 1B were including tumors with a primary tumor of 4 centimeters or greater. So this study was a positive study and was associated with a significant improvement in major pathologic response, but also event-free survival, which was 31 months in the experimental arm versus 20 months in the chemotherapy arm. And in this study led to the approval of the combination as neoadjuvant therapy for patients with potentially resectable non-small cell lung cancer. One question that now we have is whether we are over-treating some of these patients, whether we have biomarkers that can help us identifying who are those patients that may benefit the most from these treatments. And what we know so far is that, again, PD-L1 expression may be a biomarker that can predict who will be the patients that will respond to these treatments and will derive the greater benefit from a neoadjuvant immunotherapy. There have been also other biomarkers that are being explored, including tumor mutational burden, although this does not seem to necessarily associate with outcomes in this CheckMate 816 trials, although the threshold used to define TMB high and low was 12 mutation per megabase using the Illumina platform, which correspond to 10 mutation per megabase by Foundation Medicine, which is the threshold which led to the approval of immunotherapy as tumor agnostic treatments based on the Keynote 158 study. And increasing evidence suggesting that maybe this threshold is too low to identify patients who may really benefit from immunotherapy in the non-small cell lung cancer setting. And therefore, whether a higher threshold will be helpful to identify patients which may also benefit from neoadjuvant immunotherapies is still an open question. But without a doubt, this trial has changed our practice and now is incorporated into daily clinical practice. There are several other studies that have been looking at neoadjuvant immunotherapies, including immunotherapy alone without chemotherapy. And there is a phase II study from Kinecas MD Anderson Cancer Center, the NeoSTAR study, that look at neoadjuvant immunotherapy with Nivolumab and either alone in combination with ipilimumab. And the monotherapy and combination therapy has shown to be effective in this small study. Specifically, the combination therapy was associated with a high rate of major pathologic response and complete response, suggesting that, again, also immunotherapy alone can potentially be an option for these patients, but we really need to have better biomarker to select those patients for these immunotherapy clinical trials. There are also other questions about whether patients with lung adenocarcinoma or squamous cell carcinoma benefit the same from these treatments. And what we know from the CheckMate 816 study is that has seen in other settings, patients with squamous histology may not benefit as much from this treatment as patients with lung adenocarcinoma do. And of course, the treatment has been approved across both histologies, and there are benefits seen in both histologies, but the magnitude of this benefit is different. And so this suggests that maybe in squamous non-small cell lung cancer, we may think about additional strategies, trying to build on what we know and further improve clinical outcomes using neoadjuvant treatments. The other question that we have now is that whether adjuvant or neoadjuvant treatments with immunotherapies are similar or different, and whether we can optimize and personalize these two treatment strategies based on each individual patient's cancer. Each of these strategies have advantages and disadvantages, and we do not have, of course, yet prospective data addressing this question, but there are clinical trials that are trying to shine light on this specific question, and so we will hopefully will have more data in the near future.